This film presents the different injection techniques with needles or cannulas with a new feeler, Thiaziol % Redensity II, developed specially for the correction of suborbital region. The R circle, from the Latin meaning circinus, signifying circle, is a popular term that refers to the dark arc beneath eyes. This term is used for pigmentation disorders. Tear trough is a dark and depressed area located in the medial orbital rim. The palpebromolar groove refers to the hollow area located along the orbital rim in its lateral part. With age, 3 grooves appear: tear trough, palpebromolar groove, and the mid-cheek groove. The knowledge of the suborbital anatomy is essential in order to understand this delicate area. The periorbital aging starts early, around 30 years old, increases, and then stabilizes around 65 years old. The periorbital rim is mainly marked by the phenomenon of bone evolution and fat melting. The anatomy of the suborbital area consists of 5 layers: the skin, the supraorbicular fat, the orbicularis oculi muscle, the suborbicularis oculi fat, SUF, and the periosteum. The suborbital region is richly vascularized with the passage of the angular artery and the vein at the inner corner of the eye. This area is a high-risk area. Under the skin surface, a superficial fat compartment covers the orbicularis oculi muscle. Under the orbicularis oculi muscle is located the suborbiculary oculi fat, or SUF. The SUF is adherent to the periosteum of the malar bone. Under the levator labii superioris is located the emergence of the 5-2 nerve, or suborbital nerve. The injection must be deep under the orbicularis oculi muscle in the SUF. Before all injection, diagnosis and assessment of the patient's R circle, tear trough, and palpebromolar groove must be done in a semi-sitting position. It is recommended to ensure the absence of light malar bags and to perform a snap test to ensure the absence of eyelid hyperlaxity. Eyelid skin laxity is a contraindication to the injection of the R circle. The malar pocket is one of the signs. The snap bag test, we see here the different stages, enables, thanks to a simple maneuver, to visualize skin laxity of the lower eyelid. A traction realized on the eyelid, followed by relaxation, enables to calculate the time it takes to stomp the lid against the eyeball. In the case of this patient, the test is between grade 2 and 3. The medial console laxity test also enables, by the calculation of the displacement of the medial console point, to visualize the skin laxity. The lateral console laxity test is equivalent to the previous test, but is located at the lateral console. In total, all these tests enable to assess the potential laxity of the lower eyelid. There are 2 techniques of injection: microbolus with needle or retrograde with cannula. The injection should be slow, deep in contact with the periosteum. It is strongly recommended not to inject more than 0.5 milliliters of Redensity II in each tear trough and palpebromolar groove, whatever the use technique. It is also strongly recommended to undercorrect during the first session by injecting less than 0.5 milliliters and then see the patient 1 month after for touch-up only when necessary. On the view of this cadaver, a pre-hole is made down to the periosteum with a needle to give the direction to the cannula. Then the cannula is introduced, gliding without effort towards the tear trough, remaining in contact with the periosteum. We can notice that the end of the cannula is never visible through the muscle. In this view, we can see that the cannula moves through the tooth at the depth of it. At the outer part of the palpebromolar groove, the cannula is in the deep plane in contact with the periosteum. On this view, where the skin flap was raised, we can see that the end of the cannula is not visible during the injection. By folding the skin surface, we can see the end of the cannula and its positioning for filling the palpebromolar groove. On this cadaver, we can see the mid-cheek ligament marked with a blue dotted line. The removal of superficial fat enables to see the colorful hyaluronic acid located deeply beneath the orbicularis oculi muscle. When we make a pressure on the product, we can see that it is contained in a delimited area. It is therefore important to inject deeply in order to prevent migration of the product. A little hint to be able to inject deeply hyaluronic acid. You should raise and block the tissue in order to position deeply the cannula immediately. A deep tear trough visible on this patient is a good indication for hyaluronic acid injections. We will now review a complete sequence. A needle is inserted to realize the entry point to the periosteum. We can see a small bit of blood that marks the entry point. Then the cannula is introduced in the depth of the lower inner angle of the eye. The product is injected with a retrograde technique, enabling the control of the end of the cannula. Then the area under the tear trough is filled for a global harmonization. In this last case, where we will inject Redensity II using a cannula, we can see that the tear trough is very marked. This is why the injection will not only be done in the tear trough, but also below it, to restore continuity between the eyelid and the cheek. The technique remains the same. The injected product Redensity II achieves the results you see before and after. Now, we will see how Redensity II injections are performed with needles. It is recommended to use a point-by-point technique and to inject a maximum quantity of 0.5 milliliters of product in each R circle. This technique is called microbolus. The injection must be slow, deep under the muscle in the tooth, and in small quantities. It is strongly recommended not to inject more than 0.5 milliliters of Redensity II in each R circle. We will see the treatment of a patient with a microbolus injection technique. The needle is inserted up to the bone level, then oriented along the furrow. The injection is then performed. The palpebromolar groove is corrected in the same way. Finally, we can complete the tear trough, injecting in contact with the bone, directing the injection upwards. The whole tear trough is treated gradually thanks to a microbolus technique. On the contralateral side, the technique is the same. When the bone contact is made, the injection can be performed. A filling complement is practiced at the bottom of the tear trough. Treated areas of Redensity II are the R circles, the tear trough, the palpebromolar groove, and minimal palpebral or malabax. The wrong indications of Redensity II are exclusively pigmentary dark circles, large palpebral or malabax. Redensity II is the latest generation of fillers designed by Teoxane Laboratories R&D department. Redensity II is a different hyaluronic acid-based injectable gel, specially dedicated to the treatment of R circles with a natural long-lasting correction and an excellent clinically proven tolerance. The innovative and synergistic 3-in-1 formula of Redensity II combines different ingredients: a semi-cross-linked hyaluronic acid at 50 mg. The hyaluronic acid of Redensity II is a mix of cross-linked hyaluronic acid and non-cross-linked hyaluronic acid, conferring unique properties to the gel. A dermorestructuring complex composed of 8 amino acids, 3 antioxidants, 2 minerals, and 1 vitamin, enabling revitalization of the skin. Lidocaine at 0.3% for greater patient comfort. Redensity II is a different gel, suitable for the correction of R circle, thanks to unique properties: a low hygroscopic activity, allowing fewer risk of edema and swelling, a light gel exerting low pressure on the tissues to obtain less risk of edema, a needle viscoelasticity with high spreading capability, maximizing the ease of injection and positioning of the product. The clinical results show a high degree of satisfaction from patients and practitioners. The results are immediately visible after injection, as shown on this before and after picture. The excellent tolerance of Redensity II was also demonstrated on the clinical studies with an average injected volume of 0.37 mg per R circle.